We're back. Episode 16.
Excited to be here. Beautiful day. Perfect day for to be in this dark studio recording.
It's not a dark studio. It's well lit. So this weekend, I'm not going to be here because I'm handling more important family matters, but Nashville Soccer Club.
Yes. Biggest game in the history of the team.
Yes.
Probably.
I mean, we're a baby team in terms of like history, right? So, but I mean, what a run we've had in the Leagues Cup this summer. It's been unbelievable.
Well, and I don't know, not very well-known players coming to play. He hasn't lost yet, right? Messi hasn't lost, has he?
He has not lost in MLS. He scored 9 goals in 6 games.
Yeah.
Do
y'all have a plan to beat him?
We've got great defense.
Yeah.
So, I think a lot can be said for that. We have been scoring more goals. We signed a guy who came from the Premier League, Nottingham Forest, name is Sam Sturridge, and in both of his appearances, he's scored a goal so far.
Yeah.
So that's really good. You have to score goals to win. You can't just like defend.
Yeah.
So I think part of the deal is we got to score goals. But it's exciting. It's exciting, and I'm just excited to see.
It's exciting for the city.
Yeah.
I mean, everyone is like buzzing about it. My wife, who didn't know who Messi was 2 days ago, now she's getting a jersey, and we're watching the game Saturday and excited about it. I hope we give him his first loss.
Yeah, me too. So anyway, just had to shout out Nashville Soccer Club. Shout out John Ingram, our friend and majority owner, who has done an exceptional job as the steward of the club. I had to send him a text and just say that to him because he really has done a great job. He's done a very good job.
Yeah.
For a first-time sports team owner, he has done an exceptional job.
And hopefully we have the team. They may have the best player in the world, but we maybe have a better team Saturday.
Look, and this has been a big rivalry. I don't know if you know this because you don't know that much about MLS soccer history.
I always think Columbus is who I want to beat.
Well, Cincinnati is probably our really big, for the supporters, Cincinnati is like our big rival.
Okay.
And we actually beat Cincinnati en route to this final.
To get here.
So that was
the mid-season tournament, whatever it is.
Exactly. League Cup.
Yeah.
So that win was tremendous because they've been a thorn in our side. I mean, I went to our last USL game, which was the second division league that we were in before Major League Soccer. Our last match in the USL was at Cincinnati in the playoffs in a shootout, and we lost in the shootout. And in the Leagues Cup, we won in a shootout in Cincinnati. So I was so thrilled about that. And now just to sort of see us march through, beat 2 very, very strong Mexican league teams at home, and now go to the finals. It's been
and the team's
incredible.
really gelling. I mean, the beginning of the season was maybe a little bumpy, but they seem like they're coming together now.
Team is gelling.
Yeah.
Team is gelling. Yeah. So anyway, I'm just excited about that. I had to mention it. And while we are talking about while we're talking about Nashville, other things to be really proud of, Nashville has the #1 company on the Inc. 5000.
Yeah, that's right. And we know both Bill Friss and Brad Smith. They're great people. They've done other companies. We've watched this company grow, and it's really impressive to be #1 in the Inc. 5000. They're taking care of a really important area. Medicaid and Medicare, dual recipients, often in rural areas. It's a hard problem.
Yeah.
And to see them have the success is great.
Yeah, it's fantastic. I mean, I think it says a lot about what happens when you have people who really understand the healthcare system, approach it with innovative solutions, and venture capital, right? And for this to be in a time where everyone's talking about AI, and we're talking about social media, for a healthcare company focused on the Medicaid population to be the fastest growing company in America is a big deal.
It's great.
It's a big deal.
And then there's, in the top 10, there were 3 healthcare companies. And they have maybe 15 different industries, right? So 3 out of the top 10 seem pretty good for healthcare.
very good.
And then I got to throw in three of our portfolio companies were in as well. So
in the Inc. 5000, yeah. So go ahead and name them. Who?
Yeah, so Evidence Care, Script Drop, and I'm blanking on the last one. Oh, Optimize Health.
Great.
Yeah, so all three great companies. Two of them came up through Jumpstart Foundry into capital. One we found after Foundry stage, but all three are great, led by great teams. Happy for them.
Well, congratulations to Brad and Bill, and congratulations to all the healthcare companies on the Inc. 5000, and certainly congratulations to the Jumpstart portfolio companies on the Inc. 5000. It's exciting. I mean, listen, we're going to talk about how challenging this industry is, but when we see companies in the healthcare space, innovative companies being recognized as the fastest growing, I think that's only going to attract more capital, more talent to come help us solve this massive, massive problem, right? And to me, it's really, really exciting that the number one company is tackling not just healthcare, but tackling Medicare and Medicaid. That's really, really cool.
Yeah, they're helping people. And they're making a bunch of money.
Yeah.
And it's nice to do both.
Okay. So that was really cool. I think another really great story in the healthcare innovation space is this story about Moonlake Immunotherapeutics.
Yeah. Yeah. So they went public through a SPAC, which, I've been critical about. There were a lot of SPACs that
we've done a bunch of shows on SPACs.
But this is a really successful SPAC, right? They have a great technology. It's in autoimmune skin disease. There really isn't a good answer for that. And they came out with new results in the last couple of days. I think it was 2 days ago, that they really can help patients. And so they're sort of progressing through the FDA process. They really have this they're a one drug company.
Mm-hmm.
And so they needed it to work.
Yeah.
And it seems like it's working really well. They're already getting lots of suitors trying to acquire them. I don't know. I have no inside information. I don't know if they will stay independent or join up, but it's great to see, again, innovation really making a difference. Autoimmune is a really hard class of diseases. And you have a portfolio company in this space.
Yep, View Health, and they're one of my favorite companies. And part of why I love them so much is because they're focused on autoimmune. There's when we look at disease state specific companies, there is so much going on in cancer. Mm-hmm. As there should be. There is so much going on in diabetes and just general metabolic syndrome. Health issues.
Heart disease.
Yeah.
I mean, the top several diseases like that have been worked on for a long time.
Yep.
But autoimmune is really hard to diagnose. It's hard
growing.
To treat. It's growing. I think our modern environment is causing our bodies to attack ourselves. I don't think anyone fully understands how.
That's one of the big problems is we don't understand. We can't get conclusive evidence. Mm-hmm. Obviously, when you talk about the environment, that becomes political. So it's very, very difficult to make much progress on that because it's just a political issue, the environment.
And they're hard to diagnose, hard even to perceive as a patient that you have it.
Yeah. So and some of them can't be identified. Like we know it is an autoimmune disorder,
but we don't know what exactly.
Right.
Yeah.
Right. Because they present differently.
Yeah. So it's hard to know if 30 years ago this was in the population and we just couldn't see it, or if it's accelerating and more prevalent. It feels like it's more prevalent, but I don't know if we have good data for that.
Yeah. So I would say two great things maybe three great things. One, here is a SPAC that seems to be turning out well. Yes. So that's good. Two, a company focused on the autoimmune space. This is a space that providers don't have a ton of answers for. The patients are generally underserved just because of the unpredictable nature of these disease states and the fact that they're chronic in nature. They flare up at times that are generally pretty unpredictable.
Yeah.
And so what ends up being the primary course of, remedy is pharmaceuticals.
Yeah.
It's that's how we're approaching this. And drugs like Humira are very, very successful drugs from an economic standpoint, but they are very expensive drugs, and they cost payers a lot of money. And so we really need more solutions, more pharmacological.
We need more options.
We need more options.
Yeah.
We need more options in this space. We need them for the patients. We also need them for economic reasons. There needs to be more competition in this space to help people living with autoimmune diseases have better control over the flares and the symptoms.
Yeah, and I think like oncology, it would be great for docs to have several tools to use as opposed to not much to do except try to get some rest and see if you can not have stress.
That's right. That's right. So. And then the third thing that's really great is that this is a biotech story that's good, which we have not had a lot of good biotech stories. Yes. And, we may have touched on this a couple of times in previous shows, but the capital markets for biotech are rough right now. And it's largely just a supply-demand issue. There are way more assets out there than there is smart capital for those assets. And that's largely, we're not going to talk about the Fed, but that's largely because of the Fed increasing rates. People are not that interested in these really unproductive economic assets like biotech. So that's a problem because we have all this technology and all this innovation that could really, really change things. We've spent a lot of times talking about Wegovy and Ozempic over the last couple of shows. There's still more things we can do on the pharmacological frontier in biotech, in genetics, in personalized medicine. There's a lot more we can do that can offset some of the challenges we're having around labor availability and access to care and things of that nature, but not when we don't have capital willing to step up and push these things through the regulatory pathways. Well,
the entire industry structure, right? So the big pharma companies they don't do a lot of new discovery, invention, R&D. The biotech industry does that.
That's right.
Pharma is more distribution, scale, marketing, educating docs, manufacturing, of course, globally. And that's a really important function. They've moved away from the core R&D discovery of new things because the venture-backed and kind of grant-backed biotech industry did that for a long time. And unfortunately, that is very susceptible to rates and the cost of capital. And seeing a win like this, we need more of them, but that will encourage people to do more.
Absolutely.
And that's a great thing.
Yeah, so that's good. And then Stat News came out with a story this week talking about how hospitals are dialing back on venture capital investing. Now, we talked last week about how the pressures, we've been talking for many weeks, about how the pressures on health systems around their profits, around their inability to merge so that they can kind of get their financial house and their balance sheet in order is going to create interest level issues in innovation, right? Like they're so worried about being able to keep their
they
cash on hand in place.
Can't think about how to make things better 2 years from now.
Right.
They can't survive now.
And this story in Stat News, I think, is a pretty good indicator that we're tapping into something here.
I think they might have been listening to us and they looked into it.
So I mean, a couple of stories here. They talk about New York Presbyterian's venture fund, once managing roughly $40 million in assets, was essentially dissolved. They mentioned Providence Ventures, and we've known that story for a while.
Yeah. Providence Ventures was a really good hospital system venture company, and they cut back. They a lot of the talent left. It's just cut back.
Yeah, and they quoted our friend Tom Castles at Rock Health Advisory saying, "Pulling back is a silent trend. It's simply the lack of action rather than an announcement that we're pulling back." Right. So which I think that's right.
Yeah,
I think that's right. That's frustrating.
It's frustrating because we're VCs, so I want them to value it more and invest more in it. But it's also just not going to be good for the health systems. Like, you can't cut off your creation of new solutions, new ways to deliver care, new ways to work with your staff by not investing and then think it's going to all just magically get better. It's not. It takes investment of time, people's attention, hiring people and capital to figure it out. So cutting back is going to really hurt the health systems 2 years, 3 years, 4 years from now.
Yeah, agree.
And we've talked about it a lot, but I think the payers and honestly some of the digital health companies are really investing much faster now. And I'm concerned that health systems need to keep up.
Well, in the case of the payviders, it's starting to compound, right? Like the benefits they're getting are starting to compound, right? Because they didn't have any legacy baggage, right? That they needed to unwind. They got to kind of start from, at a minimum, kind of 2010 standards of care, right?
Right.
So that was a benefit. 2, they were dealing with all this data, actuary data, and then, the data they had the right to as the payers, from a claims perspective and just their membership base. So they're leveraging all this data, and their balance sheets have been strong based on different, economic windows that we've had over the last 20 years. And so they've been able to invest, they've been able to acquire, fast growing, innovative, companies. And you put those 3 things together, that's a pretty tough force for health systems to go up against.
Yeah. I mean, I think it's a lot easier given the scale the payers have and their balance sheet. It's a lot easier for them to find high margin places to deliver care, to practice and get used to it. Maybe they're doing, I don't know, they may pick some like surgery, ambulatory surgery center to get into, or something that's not an ICU floor. And then they slowly build competencies to get into delivering more and more complex care over 10 years. That's an easier roadmap to roll out than a health system trying to figure out how to find data, manage populations,
right,
and get enough scale across the country. There's only a few health systems that have that kind of scale that could do that.
That's right.
I don't think they have their data, their balance sheet, or their tech lined up, really.
Certainly not in the same place that the payviders do, right? Certainly not in that same position. So this is a predictable trend and also a disappointing trend to see happen. Yeah. And, I think it's not necessarily a willingness issue. I think it really is just there's too much pressure. There's too much pressure.
Well, the compounding works in both directions, right?
Yes.
The boards of these health systems, I think they are really concerned, probably rightly, about sustainability, just delivering on our core mission. They can't think about something in the future.
That's right. All right. So moving to the consumer market, the Wall Street Journal came out with this really nice article that is framing up consumer finances in 7 charts. It's really kind of focused on debt.
So it caught my attention.
This is a great article. The headline for anyone who wants to go check it out is "It time to worry about consumer debt? What is going on in 7 charts?" So we talked last week about the credit card balances breaching $1 trillion. Right.
Yeah.
There's certainly more to the story than that. A couple of people have come out with counter stories talking about that's true, but also the ratio of savings to credit card debt now is significantly better than it's been at any point in the last 20 years. So that's sort
of chart 2.
Yeah.
Here we have much better savings than we had 10 years ago.
Right.
But it's coming down.
It's declining.
And the reason it went up is there was a lot of stimmy checks, in the pandemic, and people got a bunch of money. They didn't spend it all on big screen TVs. But it's slowly coming down over time.
That's right. Yeah. So it is true that the ratio is better than in past times, but the trend is that this is coming down. And I think what's really interesting is that it's coming down in all bands, right? So this chart has got it broken down by income, by household income. And it doesn't matter if you make less than 50K or you make greater than 250K in your household, it's coming down. Now, it is coming down very quickly for the households that earn less than 50K a year.
Yeah. Yeah, of course. And you can see the stimmy checks. It's right. And it's obvious.
Right. All right. So chart 3 is
this is the scariest one.
Yeah. So a percentage of U.S. consumer balances moving from current to 30 days plus delinquent during the quarter. So of course, it's just worth noting that 30 days plus is the point at which your credit starts to get dinged, right?
Yeah. And often there's extra penalties and
all
fees.
Sorts of stuff starts kicking in. Yeah. So the bad snowball starts at the 30 days late moment.
Yeah,
right?
You're hustling to not get over 30 days late. So the people that are 30 days late, they can't find the money. They need to figure out something.
Right. So this chart, these are great charts, by the way. This chart analyzes 4 different types of consumer balances: auto loan, credit card, mortgage, and student loan. Student loan is flat because, nobody's paying their student loans.
That's going to change soon,
forbearance forever.
For the next 4 weeks.
Right.
Yeah.
Is it 4 weeks? Is that when it runs out?
4 weeks away.
Oh my gosh.
It's September 20th, 18th.
Oh my gosh. Wow.
And it's going to be hard for people.
Wow.
Because the average, they have it later.
Those payments are.
I think the average is $1,300. So if you are living paycheck to paycheck, all of a sudden now you got to pay $1,300 a month more. And so that student loan, no one's delinquent now, but that's going to change in 4 weeks.
So the most obvious thing on this chart is the rate of change in terms of the balances and the delinquencies on auto loans and credit cards.
Right.
Which, credit card is like kind of a straight line.
Yeah.
And auto loan is almost a straight line. So that's pretty terrifying. And then the mortgage delinquencies are going up at a reasonably scary clip as well.
Yeah. The consumers, yes, maybe you heard from some of our audience that we didn't touch on the savings, but I don't think consumers are very strong. They're not strong and seem to be weakening pretty quickly.
Yeah. Yeah. So that's obviously a bad chart. Okay. This fourth one is the number of consumers with new foreclosures or bankruptcies.
Yeah. This is good, somewhat good news.
Well, it's going to take a while for the bankruptcies to kick in, right? We're just starting to see those delinquencies pop up, but the bankruptcies are going up. Yeah. They are going up. And this is consumers, this is not companies.
Right. Yeah. This is
so it is starting to trend up after basically going down for the last 10 plus years, right?
Yeah.
Generally going down as a trend. If you were to smooth that line out.
With zero interest rates and lots of money floating around, you can refinance, you can figure out something, and then that's going to change with this new rate environment.
Yeah. All right. U.S. student loan balance changed from the previous quarter.
Yeah, so I don't know if I fully understand this balance. It went down dramatically in the last quarter.
Is that because there has to have been some forgiveness that was kicked in, because the Supreme Court backed down the Biden thing, and then did Biden not circle back and do something around?
He did something for people that work in nonprofits, but that can't be that many people.
Well, it says here student loan balances contracted by $35 billion in the second quarter, the biggest quarter-over-quarter drop in at least 2 decades. So something happened there. Mm-hmm. I wish they would have called out what happened there. That seems like a miss here. We'll have to circle back next week and talk about that, because
I'm mostly worried about
a $35 billion decrease in that budget, in that overall debt level. Something happened immediately.
Yeah. I'm mostly worried about the payments starting again.
Yeah.
But this chart looks really good, and I don't fully understand it. So that's
certainly not coming from payoffs.
Yeah.
No. That's
people didn't pay
it
off, definitely.
No, that's not what's happening. Okay, and then the average monthly U.S. house homeowner principal and interest payments on outstanding mortgages. So this is going up. This is pretty predictable. Interest rates.
It's tied to rates.
Yeah, it's tied to rates. So that's pretty straightforward. And then the final one is percent of U.S. consumer balances moving from current to 30 days plus delinquent during the quarter by state. And they're just really focused on Texas, Florida, California, and then then the rest of us.
Well, they're trying to say that the really hot states where there's a lot of population are having trouble. I'm not sure how heat affects consumer delinquencies, but maybe it does.
Yeah, that's interesting. Well, I think the big headlines for me here were really the auto loans and the credit card.
Yeah.
That rate of change was pretty significant.
Yeah.
And does not look good. That's a scary trend.
The combination of $1 trillion in credit card debt, which sure is only a little bit more than the $900 billion that was 2 months ago, but still $1 trillion is a different, catches my attention more. And then the rates for credit cards are going up and delinquencies are going up. That sort of 3-part thing makes me nervous.
Yep, agree. So just kind of, I mean, to me, this is a related story. It's not directly related, but I do think it's interesting to try to butt up against this general consumer credit debt worry. Mm-hmm. This Discover Finance,
Discover
story
came out over the last 30 days with just a series of really bad news items. So they disclosed that they have been overcharging merchants since 2007,
to the tune of $365 million.
Yeah. And then the FDIC, which regulates them, put a consent order on them, which means they're going to dig in and really they don't trust their records. Of course, they don't trust their records.
On the consumer side, not the merchant side.
On the consumer side, right. And so that was 30 days ago. And if you go up, you can see the stock 30 days ago started to go down, of course, with that problem.
Yeah.
And then on Tuesday, I think, sometime this week, the CEO resigned. Like, so the CEO
out of nowhere
stood up and admitted this wrongdoing and kind of took the medicine for the last 28 days. And then all of a sudden, he resigned. And so I don't have information, but I don't think those things fit. Like, either he should have resigned 30 days ago, or I think something else probably is going on that has not yet been disclosed. And so the stock has gone down another bunch.
Yeah, I mean, this is a story that rhymes with Wells Fargo.
Yeah, it's bad. It's systematic over decades, bad acting. I'll say fraud. I think, I don't think the Wall Street Journal said fraud, but because that word probably is too.
Yeah, and I think the reason why we wanted to bring this in, we're going to take a turn probably for the show from this point forward to just sort of talk about how Americans are doing, right? Mm-hmm. As we talked about the American consumer, how Americans are doing, and it really does seem like the pressures of the environment right now are more than we've dealt with in a long time, and they're like, they're not these obvious things, right? It's just mounting, surrounding pressures from all sorts of angles that are hard to track in any one storyline, right? But they are closing in on the average American and making life really, really hard to navigate.
Yeah, I think your margin for error is decreasing dramatically, right? So, Discover's been cheating since 2007.
Right.
But there's something about when interest rates come up and the economy is challenging now.
Yeah.
Buffett said, like, when the tide goes out, you see who's swimming naked. That's kind of what's happening. Like, there's pressure now, and people at Discover, there's a whole bunch of stuff in the closet that was not right, and now it's coming out into the light. And I think we're going to see more and more of that. As you get interest rates higher and as the economy is under pressure, there's just a lot of room for failure. Like, one misstep and it all falls apart. And that's probably good in the long run. Discover shouldn't be cheating the merchants. And I don't know what they're doing to consumers, but probably not good. But it also is too much pressure on these companies for the long term, probably.
We've talked about it's impossible to get away from the Fed because the implications.
We can't. We were trying not to talk about the Fed. We can't.
But it's just too central to the storyline. It's too central to the storyline. So, we've talked about how the rates are impacting banks, and we know that banks are critical assets to the economic well-being of the communities that they serve.
The whole society, really.
Right. Right. So the banks are hurting. We know that. We've been talking week after week about how the health systems are hurting. Right. And the health systems are also critical to the health of the community. We're going to talk about that a little bit later in the show. And now we're talking about just the consumer debt levels, right? And we know what kind of stress comes with debt. I don't know about you. I have had really bad credit. I've
been 30 days delinquent.
I've had a 500 credit score, in that range because I was going through a divorce, and I'm very thankful to no longer be in that club and have washed away all that stuff. But I've been there, and I can tell you, man, that is a rough place to be. That is a really, really rough place to be. Just the general stress that accompanies not being bankable, not being credit worthy, only being able to sort of take care of your financial needs via your wages, right? And those wages that you make, a significant percentage of those going to interest payments, right? That seem to never go away. All of that eats away. That all eats away.
Compounding interest on the positive side is incredible, right? You invest in your 401k or something, and it makes 7%, 8%, 10% over 40 years. And that's a really powerful thing to build wealth. That works in the inverse too. Like if you have a credit card with $3,000 of debt that you don't pay for a month, it all starts racking up, and the compounding works against you. The next month you owe $3,400. And then you start like taking an extra shift, and maybe you pay $300 more, but you never catch up. You're like, there's more interest than you can keep up with. And unfortunately, I think a lot of individuals are having that happen to them. And it happens to the company level too. We talked about the health systems kind of falling behind that, investing in innovation, versus the providers that are investing in it. They get more data, they get more experience, and they know what worked, it didn't work. They invest in what did work. They're sort of on the positive side of that. I think it's just sort of the same dynamic at the individual level or the company, whether it's a for-profit or nonprofit. It's the same dynamic. If you're struggling to pay your workers or the health system right now, you can invest in something that's going to be a couple of years down the future.
That's right.
And then you don't get that benefit, and it all works against you.
Yeah. So this is a generally scary trend that we're sort of tracking.
Yeah, in this economic environment with the Fed, with debt levels and interest went up, I think we're going to see more and more companies that have been hiding stuff that now that the tide goes out, we can see what's going on.
I think you and I have both struggled a little bit with the fact that, like, on a week over week basis, we come in here and we have these conversations, and it feels like we're being overly negative.
I was searching for positive stories.
Yeah,
and we started with the ink one, trying to like be good.
Yeah, no, and that is exciting, right? Yeah. But you and I are in the venture capital business, I think, because we're optimists, maybe even to a fault, right? Yes. Like just like our general personality, our general disposition. I
see the glasses half full. Yeah, like I want to have it work.
That's right. I really think that, like, we are in a very challenging window. I'm excited for when this window will end, but at the moment, we're in a pretty challenging window. I mean, these facts they just are what they are.
Yeah. And
our economy underlies, we're going to start in a little bit here talking about the health of our country, the people in our country, how we're doing. And it's impossible to disconnect that from our economic well-being. It's impossible. They're directly connected. And so these trends, to me, I'm just going to go ahead and say there's going to be a connection and a correlation to increased, health issues that we're going to be seeing.
There's no question. So, I mean, the way I think about it is that health is one of the foundational things to life. Like, if you don't have health, I mean, we saw in the pandemic, if you don't have health, you can't go to work. You're stressed about your safety, and you're trying to run around and see a doctor, or you got to take off work to do that. If you don't have your finances in order, that creates anxiety, stress that affects your health. Maybe you might eat a bunch of chips. For me, I would eat salty things. Like,
right.
I would eat a bag of chips or something
right.
that I know I shouldn't do, but I'm just, it's an easy way to have some comfort in that 5-minute moment. And I don't necessarily get drawn to a batch of grapes.
Right.
so the things that are kind of correlated together. And I think the only way through it is to try to build that foundation stronger and invest in people, try to help them recover their finances, help them recover their health, get them to talk about their fears, talk about what they're going through. Doesn't necessarily fix it, but maybe it's less pent-up anxiety. Help them understand where they can get more healthy food or help them get a ride to the doctor. And the problem is, I don't know that it's a quick fix. Like, it's going to be lots of small things that help over time. And I mean, you and I are both trying to invest in companies that are going to help make an impact in a material way in pieces of that. But there's a lot of stresses in the world right now. In finances there are, in health there is. I think overall behavioral health is, the next pandemic that we're not talking about society-wise that we should be talking about. So I don't know. I want to be optimistic. And part of the reason I like doing this podcast, it forces me to read the news in a very different way. Like, if I have to come on and talk to you about it, I need to read the damn thing much more carefully than I would otherwise. And it's hard to find, sunshine out there.
Yeah. So last week we talked about the Medicaid disenrollment issue.
Yeah.
And I think we talked about the different categories of which people who were being disenrolled might fit in.
What is procedural reasons? I mean, so we talked through all of that.
Right.
They can't find the person. They haven't responded.
That's right. And we said, look, some of these people, they've found other plans on the market. Some of these people, they're employed, and so they're under group plans, blah, blah, blah. But we did talk about the fact that certainly some percentage of, these people are now without insurance.
Yeah.
Right.
So, so before I got married, I was not very good at dealing with my personal finances. My wife does it now. But when you are behind, when you're 30 days delinquent and you're not sure how you're going to pay those things, you may not open the mail at all. So like the notice from the state Medicaid thing just is in the pile of other things, and I don't want to open all those bills. And so I think a lot of people that might need to open it, and they still might need coverage, they just don't open the mail.
Right. And so my dear friend, Dr. Catherine Gergen Barnett, who we affectionately call KGB, she is a physician in Boston, and I met her through the Aspen Institute's Health Innovators Fellowship. And we were just hanging out this weekend in Nashville.
Yeah.
And she shared an article with the group.
Talking about these issues, like Aspen Fellows do on a Saturday night.
Talking about these issues. That's exactly right. Because this is her life. She spent the last 2 decades as a primary care, family, medicine physician in underserved communities, at safety net hospitals, at FQHCs, right? Mm-hmm. So she wrote an article about how states can thoughtfully unwind Medicaid coverage, right? And she's a great writer, so it's in the Boston Globe. So I would definitely recommend people go read it. But I wanted to just call out the 5 suggestions that she made in terms of, lessons that are critical to revisit that we should be thinking about in this context. So these are lessons that she pointed out from the pandemic that could be leveraged in this situation of Medicaid churn. So I'll just kind of go through them. So the first one, and I'm actually going to read the whole paragraph associated with it. So the first one, trust the experts in the community. Let community leaders tell state leaders what works in each community through both appropriate language and cultural approaches for re-enrollment. Change communication strategies. People often do not read letters sent to their homes.
Right.
States must creatively use different platforms of communication such as social media, messaging on public transportation, etc., to inform communities about Medicaid re-enrollment and why it matters. Show up where people live, play, learn, and worship. States must work with leaders from public libraries, community centers, schools, and centers of faith and have them be partners in this effort. Build on the public-private partnerships that were critical during the pandemic. When Massachusetts needed to disseminate more COVID tests, it worked with private entities like CIC Health to quickly erect hundreds of testing sites in schools and communities. Government cannot do this important work alone. Finally, use the power of stories. We cannot understand what we have not lived. State leaders must listen carefully and thoughtfully to those in our communities who have experienced the devastating impacts of insurance loss and use their stories to continue to drive this critical work.
Yeah, and she did, I mean, we don't need to go through it, but she did it in this article where she talked about one of her patients over 10 years and the impact on his health when he was off, when for some reason he went off the rolls and then back on. And it's much easier for me as a reader here in Tennessee to understand what's going on in Boston by hearing the story of one like real person that she describes through a story. These are things that we teach entrepreneurs about getting an understanding of their customers, building empathy with what they're dealing with every day in order to get their new innovative thing adopted and used. And it strikes me these same lessons should be used by the various Medicaid agencies to find the people. And if they have a job somewhere else, then great. That's the point, is to give them a safety net and then they go off and get a job and they're fine. But if we've lost them and they're just not opening their mail, we got to try to find them.
Yeah, and I love your point, because in the absence of stories, when you're just talking about data points and numbers and percentages, it doesn't matter. Right. But the minute Catherine says, let me tell you about one of my patients.
Right. Here's what happened to him.
That's it. Like, you can't look away from that. You can't dismiss that. Like, that actually happened.
Yes.
Right.
It's a real person and he's suffering and he didn't do anything wrong except he is poor and struggling and has a lot of responsibilities and not many resources to navigate them. And so I think Medicaid's purpose is to try to help those people. That doesn't mean we have people that don't need it on the rolls, but we have to find the people that need it and get them the coverage they need.
That's right. All right. So with that, we're going to take a break and let Doug tell you about Jumpstart Foundry, where you can get involved in actually making something better in healthcare.
Thanks, guys, for the opportunity to talk about our pre-seed fund, Jumpstart Foundry. My name is Doug Edwards, CEO of Jumpstart Health Investors, the parent company of Jumpstart Foundry. We're so excited to be able to talk about early stage venture investing, certainly the need for us to change the crazy world of healthcare in the United States. We are spending 20% of our GDP, north of $4 trillion a year on healthcare with suboptimal outcomes. Jumpstart Foundry exists to help us find and identify and invest in innovative companies that are going to make a difference in healthcare in our country. Every year, Jumpstart Foundry invests a fund, raises a fund, and deploys that across 30, 40, 50 assets every year, allowing ease of access for our limited partners to invest to help us make something better in healthcare. Some of the benefits of Jumpstart Foundry is there's no management fees. We deploy all the capital that's raised every year in the fund. We find the best and brightest, typically around single-digit percentage of companies that apply for funding from Jumpstart, and we invest in the most incredible, robust, innovative solutions and founders in the United States. Over the last 9 years, Jumpstart Foundry has invested in nearly 200 early-stage, pre-seed stage companies in the country. Through those most innovative solutions that Jumpstart Foundry invests in, we also provide great returns and a great experience for our limited partners. We partner with AngelList to administer the fund, making that ease of access not only with low minimums, but the ease of investing in venture much better. We all know that healthcare is broken. Everyone deserves better. Come alongside us with Jumpstart Foundry, invest in making the future of healthcare better and make something better in healthcare. Thank you, guys. Now back to the show.
All right, we're back. So The New York Times, really powerful story, opinion, but it is a story actually, because it covers the lives of several people living in the Delta in Mississippi.
Yeah. I mean, I forget the guy's name. This is a really good
Nicholas Kristof. He
uses KGB's advice and sort of gives real stories from the Mississippi Delta.
Yeah.
And just seeing these people with an amputated foot or leg because they have diabetes and they haven't been taken care of. First of all, it's really sad. It's just as sad.
Yeah. The story is called "How Do We Fix the Scandal That Is American Healthcare?" It's, one of the things the New York Times does well is sort of the cinematic treatment that they give to the article. So the photography is incredibly compelling. Yeah. The writing is very, very strong. Kristof is a award-winning journalist, and
you scrolled through the images. But if people are listening, we'll link to the story. It's worth seeing it because there's a lot of powerful images of people.
Yep, and so I also, because I think it's powerful writing.
Yeah.
I want to just read the first 3 paragraphs. It's not just that life expectancy in Mississippi, 71.9, now appears to be a hair shorter than in Bangladesh, 72.4, nor that an infant is some 70% more likely to die in the United States than in other wealthy countries, nor even that for the first time in probably a century, the likelihood that an American child will live to the age of 20 has dropped. All that is tragic and infuriating, but to me, the most heart-rending symbol of America's failure in healthcare is the avoidable amputations that result from poorly managed diabetes. So, the first thing I just want to say is that, first of all, those are 3 brilliant opening paragraphs. As someone who writes, that's powerful, okay? But what I think is so incredibly powerful about it is he had to know that saying these things about life expectancy and about, children's likelihood of living to 20 dropping, those are really terrible things and they're data points, right?
But they're not the worst thing.
They're not necessarily the thing that might actually tack on someone's personal experience. When you talk about amputations that result from poorly managed diabetes, the really sad thing is that happens so much in America today that a large percentage of the people that read this article will have someone in their family for whom that has happened to. For me, it was my grandmother on my dad's side of the family, who, before she passed away, lost both of her legs, and then was in a nursing home. And, the key being poorly managed diabetes, right? Lost both of her legs. And then as a result of, not being properly attended to, had horrendous bed sores, and it's impossible for that sentence to not conjure up that memory. And that is a truly infuriating memory for me. So I just want to highlight what great writing this is, because it compelled me to then say, okay, I'm going to sit down and read this entire article and then look at the pictures and hear the quotes and be very, very moved and enraged, quite frankly.
Yeah. It's not acceptable. And yet it's been going on for a long time in Mississippi, but in Tennessee. So, I mean,
my grandma was in North Carolina.
Yeah.
And
so Mississippi is probably the worst. That's why he called it out. But Tennessee, I can't remember it now, but the number one thing, so we used to know the head of TennCare, and now it's changed out. But I spent a lot of time sort of talking to health systems, payers, Medicaid leaders about what are the problems they need fixed. And in 2016, the number one problem that TennCare wanted to address is unnecessary amputations. Diabetic foot is the nice way to say it. It means that the diabetic patient was not managed well and they had their foot amputated. it's terrible for the patient. They typically live 10 months longer because it's so, not for health, just because it's so depressing.
Yeah.
Their life changes. I can't get around. I can't do anything. And it's very expensive. And so it's bad all around. It's bad financially. It's bad emotionally. It's bad society. And 10K couldn't figure it out. We have started 3 or 4 companies to try to address it. It's hard because there's so many intertwined challenges. We've had some success, but there's still a lot of people that are not taken care of.
Yeah. So, I mean, this.
Then you have this image. I mean, the whole thing is hard.
The whole thing. It is. You know, the stories, the quotes, the pictures, and then it gets to this chart here that then goes kind of back, gets you away from the Mississippi story and kind of brings back the whole story of American health and how we're doing from a life expectancy perspective, right? And it bats us up against other places in the world where people live longer than Americans, right? That's kind of the whole.
Yeah. And you kind of know Japan. They eat really well. It's one sort of culture. It's one almost very, very small set of genes. They all have the same, somewhat easier to treat.
Right.
And they're fairly wealthy, similar to us.
Yeah.
I'm not surprised about Japan and South Korea, Australia. But then you see some of the countries that are ahead of us, and it's honestly just embarrassing. So Tennessee,
which is very low amongst all the states.
We are behind Iran and Morocco, Malaysia, Turkey, Algeria. We're worse than all those. And life expectancy is probably the best way just to sort of take a one stat across all kinds of populations.
Right.
And we're not performing well. I mean, we have so much more money, resources, educated people compared to these other countries. And yet we're not taking care. We're not using it effectively to take care of our people.
Yeah. This is again, another great graph and a very frustrating graph because it's good to be able to see the distribution amongst the states in the United States.
Mm-hmm. Yeah.
It is.
Yeah, Massachusetts, where your friend is practicing, is pretty good.
Well, that was one of the conversations we had this weekend.
Yeah.
Was just the difference between states and the difference between what she's able to do in Massachusetts versus what she might be able to do if she were here in Tennessee. But look, these bottom states, right? Louisiana, Alabama, Arkansas, Kentucky, West Virginia, Mississippi, Oklahoma, all of these states I just mentioned, the life expectancy is 74 to 72. And, at the top of the chart, Vic mentioned Japan and Australia, life expectancy is 84. There's no American state that high. The highest American state is Hawaii, which is, north of 80 years old. And then, in that 78 plus band, we're looking at Washington State, California, Oregon, Massachusetts, Utah, Connecticut, Minnesota, New Hampshire, Colorado, Rhode Island, Vermont, Idaho. So, look, I don't want to make this political, but there's a band of blue trifectas that are at the 78 and over level, and there's a band of red trifectas that are in the 74 and below. There could be a policy thing to look at there. It just is what it is. I'm not I'm not necessarily able to go in depth and say what those policies might be, but that's the benefit of a chart like this, right?
Yeah,
is to cause us to ask some questions.
Yeah, that's right. There's something that those states that are really low are doing wrong. And I don't know that I can diagnose it from here, but the fact that someone in Mississippi lives 12 years less on average than people in Australia, that's not acceptable to me. Like, Mississippi is one of the 50 states in the richest, most powerful country in the world. It's our job to take care of our citizens. We have to try to do that. And I think this article is showing that we're not treating diabetic patients well. There's all of these contributors called, generally called the social determinants of health that are hard to access. And I just said, I've started a couple companies trying to address diabetic foot, and there's moderate progress, but not great. But we have to figure it out. There has to they have diabetes in South Korea, but somehow they have managed it better.
Yeah. Poorly managed is the descriptor on diabetes that is the trigger for the unnecessary amputations, Yeah.
And there's all kinds of contributors. There is politics, but there also is, maybe we shouldn't put sugar in everything.
Hold on. I mean, last week when we were looking at the Medicaid disenrollment and the Medicaid churn, it was pretty clear that we had some states that were doing an abysmal job relative to other states.
Yes.
Right. And so it's clear that there is a difference in the way that some states approach health. And it should be on the table for us to discuss that. It should be on the table for us to compare that. Like, at the end of the day, we are the United States, and we should be looking not just at what other countries are doing, but what are other states doing, and how might the lower performing states benefit from adopting some of the practices of the better performing states. That's part of why I wanted to share Catherine's article, because, she's in one of those better performing states, quite frankly. And it's a state where, she has a lot of optionality. I mean, look, if you ask her about sort of, the despair that many of the people that she serves are dealing with, it's very real. It's not, there's no panacea. There's no utopia in the United States of America. There's inequality and suffering and poverty everywhere. Okay. But the political environment and the policy infrastructure and the willingness to innovate and to try some of these things, that is not evenly distributed around the United States. And so it should be on the table for us to talk about, because look, for us as healthcare innovators, if it's going to be so uneven from a state to state basis, we have to think about that, right? We have to think about the same remedies we're able to deploy in a certain set of states, we may not be able to deploy in a different set of states. Our capital may not play the same way. And I think you're actually seeing that, especially in like these Medicaid focused organizations, where if you look at the states that they pick, I look at like a city block, and obviously they're focused on urban centers, city block, right? But let's look at the jurisdictions that they decided to go in first, right? Are there any specific policy angles and Medicaid, models that they're leveraging and utilizing in those states that might be differentiated, right? That might give opportunities for more innovation, especially capital-driven innovation.
The obvious one is, did you expand Medicaid or not? I mean, that's just the don't even think about it. And I mean, I don't know. I think that there is value in driving incentives for people to be smart, to try to make money. I mean, I'm a VC. I think it's helpful to sort of give economic benefit to people. But it has to be balanced with a social safety net. We have to have a certain level of healthcare that every person, if you're in the United States, I don't care if you're legal or citizen or not legal, if you happen to be here, we should take care of you. And that's just a human right thing, that we should take care of people. And we don't have an agreement on where that line is. And each state is delivering it in very different ways. And we're in Tennessee. The number one company in the Inc. 5000 is headquartered a couple miles away. I think TennCare, which is our Medicaid establishment, does a pretty good job. And we are not high up on this. And then we have the biggest for-profit sort of number of hospitals in the country. And so it's not necessarily the capabilities. Tennessee has plenty of healthcare capabilities, but somehow we're not translating it to the actual people. And I think Catherine's article has exactly right for reaching out to see who should be enrolled in Medicaid. But it's the same set of things to reach out to diabetic patients, right? Like, you need to go to their church and teach them about checking their feet for scrapes and cuts and cutting their toenails. It's basic stuff because people lose feeling in below their knee. And so when one toenail cuts the side of the foot, they don't feel any pain. And then typically they're big enough that they can't easily bend over to clean it that well.
Or even see it.
Or even really see it, and they don't feel it. And so a small cut typically is what happens, a little scrape, but then it gets infected, and 2 months later, it's really hard to control, and then they have to amputate the foot. And so the same ideas about going to where they are, using story, finding community leaders like the minister or the high school teacher that, some of these people are not that old. I mean, there are diabetic patients that are not managed that are in their teens and 20s. And we have to find a way to get through to people so that they want to learn what we can do to help. And then we need more services to help them.
Yeah, and look, back to another one of Catherine's points, government can't do this alone, right? She highlighted how the state of Massachusetts worked with CIC Health and that, enabled them to sort of distribute all these different, COVID testing sites, right? I mean, the government cannot do this alone.
Right.
It is going to take innovative organizations partnering with the government to turn this around. That's full stop. Doing what we've been doing has gotten us here.
Right. Yeah, we are, as a country.
And unfortunately, the established health systems are turning off their venture capital programs because they are so stressed by the, inadequate Medicaid, Medicare rates that they're getting, right? So we're going to need new companies that have different cost structures, that are asset light, that are technology heavy, that can be distributed, that can go out into communities and not necessarily, require communities to come to them, and can make an impact, make a measurable impact.
Yeah. And I believe in sort of the market's ability to deploy resources in an efficient way. And also in the US, we are using a basic free market environment to deliver healthcare. We have nonprofit, but we also have for-profit. No other country, or at least no other significant country, has that. And that is wonderful in the sense that we get really world-class institutions that are doing things in the sort of healthcare centers of the country that are unmatched, right? We have the best quality healthcare in the world, but we haven't really done a good job managing how we deliver care to the people that don't have unlimited money.
Mm-hmm.
And that's part of using a market-based approach. We have to have that safety net. And for a while, we had Social Security, Medicare, Medicaid, but as the disease states have gone from acute to chronic, it's just not the same. I mean, if you break your leg, they can patch you up. But chronic care, you need much more consistent, ongoing education. Sort of, we have to teach people to think about their life in a different way.
We have to be present for people.
Yes.
We have to be present for people.
And we don't pay for that.
No, we do not pay for that.
And if you pay for it, the free market will start delivering it.
That's right.
I mean, I think it's fairly straightforward. No politician will utter the words that we have to redo Social Security and Medicare, but we do. I mean, it's you can see from the chart, it's not working.
It's not working. It's not working.
And I don't mean cut benefits to an 80-year-old. I mean, we need to deliver better fucking care.
Yeah.
And so
structure it differently.
Yes. Right.
It's not about the dollar amount. It's about how it's structured.
We will save money.
Yeah, totally. Well, again, that's why you need to turn to the innovators.
Yes.
They are incentivized to save money.
Yes. City Block's a good example. They're delivering better health and they're saving money. Both.
That's the model. Okay, so final little tidbits we're going to cover here, which is related, right?
Yeah. So South Carolina is on the lower end.
Yes.
Yeah. And this story,
by the way, we're not punching in South Carolina because we live in Tennessee, and Tennessee's below South Carolina.
Below. It just happens the next story is based in South Carolina.
Yeah. So Prisma Health and United Healthcare negotiation over health coverage. Prisma apparently sent a letter out to
all their patients.
To all their patients that said, just letting you know that beginning January 1, 2024, unless we reach new agreements, United will no longer include Prisma Health as an in-network
you're going to lose your doctor,
healthcare provider.
Basically, is what they're saying.
And I told you this reminds me of like I don't have it anymore, but I used to have Dish Network. And whenever I don't know, ESPN, one day I would turn on
NFL's going to leave.
Yeah, right.
Yeah.
I would turn on the TV and one day I go to ESPN expecting SportsCenter, and I just get this message saying unfortunately due to Dish Network's unreasonable
right. Here's a number to call and complain.
Right. Exactly.
Yeah.
So this definitely feels like that kind of tactic, right? Yeah. And then they put it on their website, saying, hey, we're our hospitals and physicians will be out of network for the following plans, and it lists, United Healthcare, the Medicare Advantage. So, I think that I think two things, because we're gonna go into an extended story about United Healthcare in a second, but I think two things. One, I think this is obviously a negotiating tactic.
Yeah.
That
it's perfectly acceptable. It's
a negotiating tactic.
It's
it's a negotiating tactic. But I do, you had brought up to me the story about how locally there was an anesthesia.
That walked away from Vanderbilt.
A group that they had 80% concentration. And they walked away, and then it literally did disrupt availability of surgeries, right?
Yeah.
And so I don't know enough about South Carolina's coverage to say this with strong confidence, but my understanding is that Prism is a very, very big, strong health system in South Carolina. And I don't believe that Optum has a really strong presence in South Carolina in terms of the Optum Care business model,
which is owned by UHG.
Right. Right. So I think that this feels like that kind of, hey, we've got the network and we're just going to go ahead and message to our patients because they have a stronger brand relationship with us than we think they do with you from a negotiation perspective.
But United has a PR team too.
Yeah.
So they pull up they commented to the reporter.
Oh, yeah.
Pretty good comment. And basically said, Prisma Health is demanding a 24% price hike over 15 months that would increase healthcare costs by $63 million, with more than $46 million coming from the budget of self-funded employers. So we're committed to keep negotiating.
Yeah, they just dropped the numbers.
Yeah, so it was kind of fear and this mean payers doing bad things, and then UHG just said, "Well, it's 24% increase." Did you get a 24% increase this on your wages this year?
Right, exactly.
It's all posturing, but I think the reason to bring it up is that it would be much better for both United and Prisma to stop fighting over this and just deliver care to the people in South Carolina.
Well, so I don't have Prisma's books, but again, my sense is probably that there is some desperation on their business model that led to this negotiation. I don't know the management team. I don't know this. I don't know this health system really that well at all. But I can't assume, first, knowing what we know about the state of health systems in America, that this is them purely gouging for profits, right?
No,
my sense is they are losing, they're probably losing money.
They are definitely losing money. They maybe could manage their system better.
Yeah, that's an entirely different conversation.
Well, but that affects, do you need to raise 24% or should you manage it better?
This is what many of these management teams at health systems know to do, is demand higher rates.
Right.
That's their tactic, as opposed to innovate, find inefficiencies, take those as opportunities to create more margin, create net new revenue lines, right? That are ambulatory in nature or technology driven. Those are things you can't really do when you're winding down your venture businesses and your venture investments.
Right. Yeah. So we don't know where this will end, but it's interesting just to see the kind of the bickering back and forth.
And then part two of sort of the United Healthcare story here is we missed this because this rolled out August 1st, but United Healthcare put out a release saying that prior authorization reductions will equal nearly 20% of all overall volume. So they've found codes across their commercial plans, their exchange plans, their Medicare Advantage plans, their community plans. So that's the Medicaid plans. They have found swaths of codes, and they're not the same because I've looked at the different plans, and like for the commercial plan, there's a bunch of like genetic testing is there, radiology is there. There's a bunch of site of service, procedures that are in there, and there's sort of different stuff under Medicare Advantage, different blocks of codes. So somehow, because UHG broadly is just an incredible data-driven company, I think they've figured out, prior auth is actually not helping us, and it's certainly going to be a popular thing to drop prior auth on these codes.
Patients and doctors and everyone hates prior auth.
Yes.
Like my doctor wants me to have this diagnostic test, and I want to get it.
I want to get it. Yes.
And then I get stopped.
You get stopped.
And I have to call and get a prior authorization. It's really a delaying tactic to sort of cut back on utilization.
Yeah.
At least that's how I view it.
Yeah, but it also sometimes you don't get the prior auth.
Yeah, sometimes they don't give it to you.
Yeah.
Right.
I've had that happen for an MRI, actually.
Yeah. And so
it was not with United Healthcare.
People hate it. And I think they hate it because they want to get whatever their doctor's telling them, whether that's evidence-based medicine or not.
Right.
I trust my doctor.
Right.
And I know intellectually that there's thousands of new papers every week that come out that UHG is probably ingesting and understands all the evidence, and my poor doctor can't read them all. I still trust him. He or she is the one that I know. I went and saw them, and they want me to do this thing.
Right.
And now this mean payer is not allowing it, or at least not allowing it without reviewing it all. So people hate it. My belief is that United is really smart and has a lot of data.
They have the data.
And I think they are saying, fine, you don't like prior auth, we're going to cut back on prior auth.
Yeah, it's a great move.
It's a great
for them
PR move.
It's more than a PR move. I mean, I think it's you're literally taking one of the biggest complaints off the table, at least for a large series of codes across these plans.
And we looked at it. There's a lot. I mean, it's a lot of codes. A lot of codes.
It's a lot of codes.
But they used to have automatic pre-auth required.
Right.
That now they're saying in September, and then there's another date in November. It's pretty fast.
Yeah.
They're going to not do that anymore.
Yeah.
That is great. And I also believe that they probably are running their business still to appropriately manage the risk.
Of course.
And so,
of course,
they have other levers. I read as they have other levers to pull, and they don't need this like kind of very blunt, crude instrument.
It's a crude instrument.
Right.
That's right. They are evolving, leveraging data to be able to manage the risk that prior authorization was in place to manage in a much more elegant way. That's what this says, right?
Yeah. And then if you go down, sort of buried, the thing that I really was interested in is this gold card program for provider groups that meet eligibility requirements. So if you're eligible in the United Health Group policy as a provider, I think that means you don't submit a lot of claims that are rejected.
Yeah, you probably don't have a lot of fraud, waste, and abuse issues and things like that. Yeah.
Then you get the gold card, and that allows you to get more things pushed through without any prior auth.
Right.
And that sounds great.
It's a fast pass at Disney.
Yeah, except what if you're not a gold card provider?
Well, I mean, you might not deserve to be a gold card provider, right? I mean, like let's just take it on its face. I mean, it could just simply be your performance does not merit the trust.
Yeah. For instance, you have we have found multiple claims where you were not following evidence-based guidelines, and you order this genetic test for which there is no change to the treatment. So that's a very common thing. Like, there's this new genetic test. It's really cool. We'll learn what the genetic makeup of this tumor is, but I'm not going to change your treatment. And so I think United Health Group would say, well, why would you go through the process of making the patient go down there, billing for it, when if there's no treatment change, there's no real point to it. And so if you establish your track record, probably over millions of claims,
right,
that you are doing best efforts, or
lots of claims.
I mean, providers over 10 years will have a lot of claims.
Oh, yeah, fair point.
Well, maybe it's not millions, whatever.
Fair point.
A significant number of claims where you have enough where you can say, okay, this system or this provider group or this individual doc is on balance really following evidence-based care or a good actor, and these other groups are not. That probably is good overall for the system.
Well, it's certainly an evolution. I mean, I think most people will say prior auth.
It'll be interesting to see if other payers cut it.
Well, it will be interesting to see if they cut it, because it will signal whether or not this is a unique capability that United has in terms of, their just actuary data, machine learning, models. Or if they've just sort of decided, like, after years of looking at it in retrospect, it doesn't really make that much of an impact. And
the cost for us to field these calls from mad patients and doctors, and then we authorize 3/4 of them anyway.
Right. Yeah. So interesting. Just an interesting development in the overall landscape of payers and providers, and how. Yeah, I mean, I've said on
this pod previously, I think that United and other payers are really going to use big data and AI to do a much more effective job at, kind of questioning claims that actually should be questioned, and then let claims that go through that should.
Yeah. Well, to that point, when we were talking about AI and where it can be used by innovative companies, sort of two things. One, I know we talked about prior auth, right, as one of the areas. But two, we have talked about how AI for startups, because it's really going to be large organizations that have the data and have the ability to, like, crunch all these numbers, that are really going to benefit from AI for the most part. And I think this is an example. We talk about it in the non-healthcare space, how a lot of AI is going to accrue to, your Googles and those kinds of organizations. But this is a perfect example of, well, let's not plan on venture-backed companies solving prior auth, because United's just going to do it.
Yeah. I mean, I think unless you have some proprietary data source, and I question entrepreneurs when they claim to have a proprietary, it has to be actually like no one else has this. You scraping the web, you can stop right there. That's not proprietary.
Right.
But unless you have a proprietary data source, OpenAI, Anthropic, I mean, the big systems are already known. They're way ahead, and it's billions of dollars.
Yeah.
And then you're not going to get an advantage. No. Right? So the only time a startup can have an AI thing that I think works, if they're sort of adding to that base large language model with some special data, and I'm looking for that, but I haven't found one yet. There aren't that many.
Yeah, it's going to be interesting, because this is one of those instances where we can assume certain things that exist in the healthcare industry will always be there, and that they sort of serve as scaffolding for problems for us to solve. But what if prior auth just goes away in the next 5 years? Like, the payers just all do away with it.
Yeah.
Then that whole problem set, it's just not a problem anymore. There's no more money to be made there. Right. So it is something to just pay attention to and think about, and just keep in mind these different workflow things.
I mean, that would be good.
Oh, no, it would be good.
And I want to make money, but I'll be happy to make money in some other area.
Well, you think it would be good but you don't have a prior auth, efficiency-based company that just assumes the prior auth is a forever
I don't have
thing.
that in my portfolio. That's right.
That's what I mean. That's
that would be terrible. I mean,
right. Right. All right, man. Good show. Good show.
Yeah. All right. So Saturday, big game.
Big game.
We will see y'all next week with Nashville being the champion.
That's right. Till next week. Bye.